Good evening, everyone. Well, state surveyors occasionally request to see documentation that the nurses have had education in respiratory therapy as it relates to the MDS, so that's what we'll cover today. In order to really gauge that, I want to talk a little bit about how reimbursement affects the nursing home setting. So with our inflation rate this year of 4.2%, it's going to be even more important that we try to get as much reimbursement as possible from as many areas as we possibly can. Right now, 60% of most nursing home residents are medical assistants, and we would be lucky if we broke even on those residents or made any kind of profit. Most of the time it is a bit of a loss. It's estimated that $22.46 are lost each day on these residents. And for one resident, that's not a whole lot, but bring it all into perspective, that is a lot of money that is being lost regularly. For each facility, they may lose up to $1 million each year just trying to pay for these residents that are in the facility. So we make up for it by taking as many skilled residents as we can because those payer rates are so much higher. If we look at our highest paying resident, that is the ES2, that is $850 a day. There's a lot that you can do with that. The lowest paying Medicaid resident is a PA1, and that is $217.25. Now, looking at things like food costs have definitely gone up recently. The facility is paying about $2,000 more per month in food costs than they did in the year prior. And really, we should be spending about $4 per plate on food when it is all made conglomerately. Medicaid payments ultimately drive staffing. You have to have money to pay for staff. And in our case, we want to have good staff, which means we need to pay competitive wages. With those wages sometimes comes some very hefty bonuses, whether they're sign-on bonuses, stay late bonuses, pickup bonuses, you name it, we have to pay it. We want the good staff. We want to keep our staff. When funds decrease, we see a lot of times a correlation with decreased quality. Right now we are a 5-star facility. If we start running out of money, that could also drop. Less skilled residents, more Medicaid residents could equal poorer care in the long run. So to lift nursing homes up, we do need higher reimbursement, and ultimately it's going to be an increase in public resources to make it happen. Now you hear that residents that are on a duo neb need a nursing assessment done, and it needs to be 15 minutes per day. If you get 14 minutes, we don't get paid for the day. We have to code 0. If you do 14 minutes per day and you do that all 7 days, that's only 96 hours. That doesn't cut it. We need 105. If we don't have that, we have to code 0 and we don't get the reimbursement. So looking at the MDS, it is a small section, but it is a significant section. We have to get the total minutes. We have to record the total of number of minutes of therapy that was administered to the resident in the last 7 days. Record the number of days the therapy was administered for 15 minutes. So you might be asking yourself, what constitutes 15 minutes? Well, a lot of that is going to be your nursing assessment. To make this easier, we also laid this out. Just get it on here. So when you go into a room, you are going to listen to lung sounds. You're going to record lung sounds before and lung sounds after. You're going to record your total minutes of therapy, which should be at least 5 minutes if you're doing duo nebs 3 times a day. 5 minutes 3 times a day gives us our 15 minutes. But hey, if you get to 10, that's awesome. O2 saturations, record those. Pulse before and after. Remember, pulse might go up after someone has taken an albuterol. Respiratory rate before and after. And of course your signature. There are many things that we can count in that time, and I wrote them down here. Teaching. If the resident is there, you can count your time teaching. If family is just there, you can't. The resident has to be present. Any training that you do on a nebulizer, you can count. You should not be counting puffers, okay? You can count incentive spirometry, that is fine. The time that you are physically spending with the resident delivering the therapy, so that is the setup, the administration, and the cleanup. You just can't exit the room. You have to stay with them. So do not count the time away from the resident. And you must document the exact minutes. The MDS manual says do not round up to the nearest 5 minutes or down to the nearest 5 minutes. We want to know exactly what you spent. And all of this takes place in a 24-hour period. We want 15 minutes for 24 hours. So, in order to make your nursing assessment worthwhile, you need to make sure that your lung sounds are correct. So, RALs, also known as crackles. This is something that you're going to hear. Most commonly, it's a short explosive sound, maybe a bubbling sound, rattling, clicking, and this is going to happen more than likely when you're breathing out. There could be fine crackles, which are high-pitched, and there could be coarse crackles, which are lower, and that comes from air in the fluid sacs. There's stridor. That is a harsh squeaking, could be high or low. Rhonchi, this is a low-pitched wheeze, could be a snoring sound that you hear when the resident is breathing out. This normally comes from your bronchial tubes being loaded with mucus. Residents sometimes need to cough that up, and a nebulizer can help with that. Whooping, well, I bet we can guess what that sounds like. Heard whooping cough before. Rubs are also very common, and this is from inflammation in the pleura. So there could be fluid in your lungs, or there could be pneumonia, and it sounds like leather grinding together. So picture that sound. And then wheezes, I think we've all heard this at one point or another. Those with asthma will frequently have your wheezes. So those are all things that we are going to document in our record. We should make a nurse's note. We should chart lung sounds minutes, O2, pulse, respirations, and time. We want it to equal 15 minutes. We want to include teaching, training, incentive spirometry, the time that we deliver the neb. We do not want to count the time away from the resident, and we need to count the exact minutes. I'm happy to go through any of this with any nurses in person, but we do this so we can maximize the reimbursement that we can get for each resident receiving our care. Maximized reimbursement is more money, which is more money that we can spend on our residents and our staff. And that just improves our overall well-being. One of the biggest examples I can think of is a resident that is frequently has COPD and needs his head raised in bed. Just charting that we need to raise the head in the bed could result in an extra $70 a day for a resident. If we don't catch those little things, we don't get the reimbursement. My dog is having a great time over here. Brutus, what are you doing? He's obviously not paying attention. Thank you. Have a good night.